We're starting out this segment with Paul Seegert. He is the managing partner of PCS Advisers. Their game is helping employers to unravel the multi-level melange of healthcare benefits and costs in an effort to help them provide more efficient, comprehensive coverage for employees, but while not breaking the bank and crippling the fiscal health of the employer. Welcome to the show, Paul.
Thank you. I'm glad to be with you today.
Now, I noticed today you've got a couple of pieces. You're addressing PBMs, pharmacy benefit managers, their role in it, and their role in some more or less hidden cost increases. I don't know if the average listener really understands the concept of a pharmacy benefit manager, but ages and ages ago, like back in the 80s, when I first got into the healthcare industry, everything was pretty much fee for service. You went to the doctor who was in a single practice. He might have written you a prescription or did a procedure. You paid for your prescription or paid for the procedure. And if you were fortunate, you might have an indemnity policy where you sent in a claim to your insurer and they would reimburse you for whatever portion was available. But then soon, healthcare became an employment benefit and things started to get really complicated. Patients were herded into large groups. And you were no longer a person, you became a life in managed care parlance. Providers had to group together to contract with companies so they could take care of these patients that had been taken in by the healthcare providers. The insurance companies eventually determined that it would be a little more efficient if they carved out the pharmacy benefit, patient's prescription benefit, to companies who specialized in that and could effectively, through volume of lives covered, leverage formulary access with the various pharmaceutical companies. And as a lever on achieving greater companies have come from. So if that helps you, I appreciate. I'm glad. If it just confused you, I'm sorry. But and it is a confusing melange, even if you worked in it as it was evolving. But Paul, I will turn it over to you to disclose how some of these PBMs and their hidden administrators and administrative costs are causing some problems and inflating costs.
Yeah, I'll tell you, picking up that story where you left off, back, if you don't have to go that far back and to find a time when those pharmacy benefit managers who were supposed to be negotiating on behalf of the consumer to get better value would manage the formulary for a health plan and maybe make $1 each time a drug was dispensed. And fast forward that to today, and you have 41, I think I'm up to, at my last count, 41 different fees they can attach to the cost of a drug, which inflates that total cost of that drug 30 to 60%. When you look at drugs like insulin as an example, insulin is Humalog, most commonly prescribed insulin today, would cost a typical health plan would pay $550 a month to have someone on that drug. 330 of the 500 is now represented by fees added to the cost of the drug by the pharmacy benefit manager for the privilege of having it on the formulary, 60% of the total. So it's gotten way off track, and it's one of the unintended consequences of the ACA in terms of how extreme this has become. But it's become the most inflationary part of our system. The cost of pharmacy costs in health plans is growing at twice the rate of any other cost driver in plans when we look at them today. It's just become a massive, massive problem. And we find health plans on a daily basis where more than 50% of the total spend in the plan is paying for prescription drugs. And so when we look at what the government is doing to potentially doing to fix it, we don't really ever find solutions. The industry operates with so much secrecy, and they have such a good ability to give politically in a precision way to the right members of Congress that this system has really never been threatened in any serious kind of a way. and their profits just continue to climb. And it's interesting to me because, as you pointed out in your introduction, most people, the average American, doesn't even know that there is such a thing as a pharmacy benefit manager, and yet you have this player that's a part of our system that is massively inflating costs. And then anytime you see conversations in the media around big pharma, it's usually vilifying drug manufacturers who have a declining revenue on lots of prescriptions year over year as the revenue to the pharmacy benefit managers grows. So it's a problem that doesn't get solved pretty much by design, and it's not funding R&D. That's not the real reason drug costs are high. It's because we allow this kind of thing to go on unchecked, and we don't have the transparency we need in the system to fix it.
Definitely. Well, a lot of people don't understand. They think it's a relationship between them and their insurance company or their health management organization. Don't even realize that their drug benefit is basically capitated, and it goes to the PBM, who then uses that amount to negotiate with the pharma companies.
Yep.
And they have a tiered formulary. I mean, people wonder why some things are easy to get, some things aren't. The bottom tier, first tier, generics. Second tier might be some branded name drugs, but normally drugs that there are a lot of similar drugs on the market, so the PBM can negotiate with them, charge them a rebate to get access on the formulary. Copays will be a little higher than tier 1. Then you have tier 3, which might be single source drugs or others that the pharma would really love to get on the formulary, but access is largely restricted, and they'll extract even larger rebates from the drug manufacturer for any formulary access. But there's lots of other mechanisms that PBMs use to reduce utilization. But and if you ever need a tier 4 drug, basically forget it, or start calling around to see what it is out of pocket. Because sometimes on those level of drugs, the PBM will charge more than retail. But it's exactly a complete game, and PBMs, since they control access to the patient, are in the driver's seat. And as these articles say, particularly with respect to their treatment of pharmacists, some of their techniques can be rather abusive when you talk about spread.
Yeah, no, without a doubt. I mean, they're driving the small pharmacists out of business, and it's consolidation like happens in so many industries, but the story behind this consolidation is pretty incredible. Pharmacists' revenue is on the decline. The manufacturers make less year over year on a drug, and there's one clear winner, these pharmacy benefit managers. And then when you follow the trail, to me, what an interesting story it is, and an unfortunate one, to follow the trail of where do those dollars go when you look at that $330 out of the $550 for insulin for a month, that 60% of the total. Who has their hands in that 60%? It's a lot of players in the industry. You've seen a lot of consolidation happening there too, where insurers of the big handful that are left, the Blues, United, Cignas, Aetnas, Humana's, they're aligning themselves in this vertically integrated model with these pharmacy benefit managers. There's acquisitions going on because it's such a huge profit center, and they can essentially, if you look at it in a real simple way, a pharmacy benefit manager and an insurer can come together, and the insurer can say, hey, I'm going to outsource our pharmacy benefit management function to you, allow you to overcharge for the drugs, and then you give some of that back to me, and I'll take it outside of the accounting of the health plan that you're overcharging, so I can still meet the medical loss ratio rules of the ACA and continue to drive growing revenues for my company. And it really is that simple in a way.
Now, Paul,
as far as what they're doing.
Let's look into that in a little more depth. I have to cut for a commercial break. This is the Andy Caldwell Show. We'll be right back. Hi, back with the Andy Caldwell Show. We're on this Wednesday afternoon continuing our conversation with Paul Siegert, Managing Partner of PCS Advisers. Paul, I'd like to look a little more into these topics you have. You talk about PBMs clawing back payment due to the spread for pharmacists. Now, in the old days, when we talked about working the spread, it was, well, not, not legal. It had to do with providers or pharmacies working the difference between average wholesale price and wholesale acquisition costs in a certain manner to amplify profits. But this is different. Is this spread, does this have to do with just dispensing fees the PBMs pay to pharmacy, or does it also have to do with acquisition costs of drugs? I was a little cloudy on that.
Yeah, it's both.
Okay.
It's both. I mean, they just come up with more and more ways to squeeze more revenue out of a drug. I mean, another example of it would be when that member walks into a pharmacy and needs a really high dollar drug, and at the point of sale, the pharmacist has to say, oh, you've got to get approval for this. And really, it's not about approval. They're going to approve the drug. They're just directing that sale out of that pharmacy, taking that potential for a more profitable sale from the pharmacy and taking it direct, or to a mail order pharmacy or an online pharmacy where they have a better revenue sharing agreement or a more advantageous connection. So it's a sad state of affairs that we're up against as consumers. But there are some, and actually before I get to the good news, there is some optimism. It's not all bad news. Employers are fixing this. There are employers out there in the marketplace that are finding ways to clean this up. I don't expect the solution will ever come politically, but it can come from the free market. It is one employer at a time. And I'd love to share a little bit about what I see that's optimistic. But before I get to that, the thing about the system as it stands today is that rebates, which we've talked a little bit about, that these pharmacy benefit managers collect from the manufacturer that have grown and grown and grown and now represent a really tall percentage in the total cost of some drugs. That's become more public, which is what we need. It's become more transparent. And so then you have employers running large health plans and other stakeholders in the game that'll say, look, if you're getting these big rebates, we need some of that. You need to share some of that with us because it's inflating our costs. And so as that has become more public, there is a trend where some of those rebates will get shared back to those health plans. But the sad part of it is when you look into some of this recent reporting, these pharmacy benefit managers can simply add another fee and continue to inflate the cost of drugs. So their administrative fees grew over 50% in the 2-year period, 2017 to 2019, and it was simply to compensate for the fact that they were starting to give some of their other sources of revenue. They were starting to pass them through to the health plans. So they just continued their game under a different name, a new fee. So they might be giving that employer whatever that amount is, $100, but if they're going to add another $100 to the cost of the drug, is anybody really winning?
No.
Only the pharmacy benefit managers, unfortunately.
Yeah. So is there a brighter side to this? The company I was at, a pharma company, we had, 15,000 employees. We were self-funded, our health care, and the insurance company was basically just an administrator of that. But the real crush that's really serious and felt most seriously, sorry for repeating myself, but is by small and medium-sized employers. They're really the ones between the jaws of the vice. Any solutions or hope for them?
Absolutely. Yeah, absolutely. That trend of aggressively handling this area is coming down market. It's not just for the employer with 15,000 employees anymore. You can have an employer, and we do it on a daily basis, and we focus on a lot of times on those employers that are in that size range that you just talked about, that mid-market employer with 100 up to 1,000 employees, let's say, on their health plan, or up to 2,500 employees on their health plan, that are getting absolutely murdered by the system. We're working with them to show them there isn't anything that stops them from setting up their plan with some of the very same vendors that would serve a plan of 15,000 employees, and getting some of the same added transparency. And that's really the optimistic part of this whole conversation to me, is that when you look at our industry, this whole employer, healthcare in general, and then you focus in on the employer-sponsored health plans, which shoulder a lot of cost in the system, period, it's coming down market. We're now at a point where it's about a 50-50 split nationally, where those groups in that size range that I mentioned and that you pointed out are oftentimes the most abused. we're at about 50-50 now, where those 50% of those employers are building a plan that's alternatively funded, that gives them some of the flexibility to pick vendors that will agree to operate transparently, won't add all those 41 potential fees to the cost of a prescription. And by doing so, they're able to dramatically reduce costs for the plan and for the members in their plan, and make healthcare, or the way that we pay for healthcare, actually affordable.
Oh, that's great, because they're the small and mid-sized. They're the ones that really need the help. They're the ones that the excessive health care spends on their employees' plans. That's coming out of maintenance, purchase of new equipment, other benefits, salaries, raises, expansion.
Exactly right.
It really hurts their potential in the marketplace. A lot different picture than some very, very large companies. So they really are the people that need the help. So yeah, any efforts along those lines are vital. And then again, remember, most people in this country work for those small and mid-sized companies, not the giants.
I agree. You can see it's not true just in this cost driver, but then you look at facility charges at hospitals or surgeries or all the big cost drivers in our system. And it's those employers in that size range that we're talking about, they're shouldering so much cost. It's for another show, but just kind of a tidbit. The average hospital has more than 150 prices for every procedure they perform. So it's no reason we have single-digit percentage of hospitals that are complying with the transparency rule that kicked in on January 1 of this year. They don't want the average consumer to know that. So we have the same kind of silliness that just is pervasive throughout our system.
Definitely. If people want some interesting reading, just look at those explanation of benefits that they get after they've had a hospitalization or something. Look at the top line and then look at the bottom line, what the reimbursement is. It's an enormously complex situation. And going to electronic medical records and that system, just the opposite. It's wound up providing the simplification and efficiency. It's just generated confusion, I think, at much greater warp speed.
And they just auto adjudicate claims. So in the billing party knows the computer's just going to approve this. I can almost put anything I want on it, and it'll get approved. It's incredible.
Boy, so since we're talking healthcare, in our final moments, we're going to change gears. I'm going to give you a quiz. Okay, it's not
I'm ready.
Too serious. What do these people have in common? Jimmy Walker, Joe Namath, George Foreman, William Shatner, and John O'Hurley, the famous Peterman of Seinfeld.
What do they have in common?
You watch much television?
I do.
They've been doing all these ridiculous, deceptive, thinly veiled Medicare Advantage plan advertisements that since open enrollment ended yesterday, we don't have to look at them for another year.
Agreed.
Oh, yeah. People don't really realize they need to think twice when they look at that stuff. It's not all about just calling that number and getting help.
And getting some free stuff.
That's for sure.
Beware. Buyer beware.
That's for sure. Well, we've got about 2 minutes to go. You have any, as we're getting near the end of the year and everything, do you have any observations or predictions?
Well, one of the easiest things people say, there's nothing certain but death and taxes, but I've added a third to the list. Death, taxes, and your health care, your health insurance premiums will go up.
That's for sure.
And so that's unfortunate, but it's amazing to me when you look at the system and the fact that health insurers' claims were down 70% through COVID. It wasn't just their good-hearted nature that encouraged them to waive people's out-of-pocket costs for a while there when they were hospitalized from COVID. It was the fact that they had money piling up on them, and they were going to have to refund some of that based on the medical loss ratio rule. But not much got refunded, and another round of increases came, and they were able to pretty consistently across the country convince the heads of the departments of insurance of those states why they needed to raise rates yet again, despite claims having been down 70%, posting double the quarterly profits over prior years in many quarters because of pent-up demand from COVID. So it's a system that if we could fix it in one word, it would be transparency. We don't have it. We don't have a free market. We don't have a free market in healthcare, but it does work. Look at LASIK and how the quality has gone up and the cost has gone down because we've removed this intentionally complex insurance payment model out of the way and allowed a free market to perform. That's what we need throughout the system.
Simplicity, what a concept. The value equation that used to exist has been completely erased as the payer is far, far away from the recipient of services. Well, thank you very much. Interesting show. We need to cut to a hard break for the network news. Andy Caldwell Show.